is Alagille Syndrome 101, and I will say that you have got such a great agenda coming up in the next couple of days that I can't cover everything. So what this is intended as is really the overview and kind of like the amuse-bouche or the appetizer to such a fantastic symposium that's coming up. I'm sure that there will be lots of questions after, or there may be lots of questions. And I also am sure that most of them are going to get answered by some of the great presentations that are coming up. So this is a little bit of a whirlwind, but hopefully it's just a good an introduction. I think the other thing to say as we go through this talk is that we've got a variety of experience of people who are listening. So I know there are some of you who've been on your Alagille journey for quite some time, and there are others who may be right at the beginning of their journey. So I have, to some extent, tried to sort of cater this to people who may be near the beginning of their journey, just so that we can have everybody on the same page as we go through the symposium. Right, so my objectives for today are to really try to recognize and appreciate the multisystem phenotype of Alagille syndrome. And by phenotype, I mean to try to appreciate all the different clinical features. You'll hear that term a lot coming up as we discuss Alagille syndrome, and that's just a fancy word for saying clinical features, clinical signs and symptoms. I'm going to focus a lot on the liver disease because you've got experts in genetics and cardiology and mental health coming, we've already heard from Dr. Albert, from others later on. So I think I really wanted to focus on what I know is my area of expertise, which is the liver disease, to talk about the management and the natural history. And then you've got a great session coming on transplant. So hopefully mine will stop, and then the transplant team will take over from there. And if you're wondering who the picture is in the corner, that is actually Daniel Alagille. Daniel Alagille was a French pediatric hepatologist who was the first one to describe this condition, and he gave it his name. And it is a little bit really why it is hepatologists, liver doctors, who end up, I think, really coordinating a lot of the care for the majority of our patients and families, really because of his legacy. So a nod to him. I'm sad I never got to meet him, but really, we owe him a lot. So, big overview of Alagille syndrome. It's a developmental disorder. By that we mean it's a condition that is sort of determined in your genetic code, and it leads to disruptions in the way that the body develops early on. So it's not something that you acquire, or you can develop Alagille syndrome when you are 25. It's something that comes right from the beginning of development in utero. We used to predominantly rely on making a clinical diagnosis, and we used to be able to say if you had particular clinical features in at least 3 out of 7 organ systems that you had Alagille syndrome. But now really we rely a lot on making a genetic diagnosis, and that's very, very easy to do. And it's easy to do because, unlike most rare diseases, in most rare diseases, you need 2 copies of a gene to have a rare condition, a rare disease. In Alagille syndrome, you only need 1 copy of a disease gene, and the predominant disease gene is JAG1. And if you have clinical features of Alagille syndrome, more than 90% of the time, we will find a mutation in JAG1. There's a second disease gene, Notch2. I'll talk a little bit about that, but of course, genetics will be covered very well by Nancy Spinner this afternoon, but I'll touch a little bit more on the genetics. This issue of saying it is autosomal dominant means that you only need 1 copy, and that means that it's easier to make a diagnosis. And then when you see this other phrase, 60% de novo and 40% inherited, what that means is that 40% of the time, that JAG1 gene that has a variant or a mutation that gives you Alagille syndrome comes from one of the parents, and 60% of the time it's new in that baby. So we know quite a lot about the genetics of Alagille syndrome, but I will also tell you that it's a very, very variable disorder. And this is going to come up throughout the next 2 days, that it is variable. Patients, individuals in the same family have very variable expressions of disease. It's variable between families, it's variable within families. And so variability is just a very key feature. So we can't make predictions on what somebody's Alagille syndrome will look like based on their mutation, based on which family they come from, based on what their liver biopsy looks like, based on where they live in the world. It is variable. So what that means is each of you who is affected with Alagille syndrome, either in a family member, in yourself. You are unique, you are special, and we as healthcare providers have to personalize our care to you. Just because I may have seen several hundred patients with Alagille syndrome, I can't predict what your disease and what your journey will look like. This is the big overview image that we use. These are the 7, as it were, organ systems that we think about that can be affected by Alagille syndrome. Up in the corner here, if you can see my pointer, that's a liver biopsy that shows the classic feature of bile duct paucity. What is bile duct paucity? That because of the JAG1 mutation, the bile ducts don't develop properly. We don't have enough bile ducts, so there's a paucity, a lack of bile ducts, and that leads to the liver disease. So that's what we mean by bile duct paucity. We see skeletal abnormalities, and the most common one is butterfly vertebra. That's what the arrow is pointing to here. We see eye findings, and here the arrow is pointing to posterior embryotoxin, which is just a thickening of 2 membranes in the eye. We see heart defects, very important, and we're going to have a whole session about that this afternoon, of issues within the heart, major structural defects, but also lesions in the blood vessels outside the heart that go to, particularly to the lungs. We see kidney issues. This is something that we call a horseshoe kidney, where the 2 kidneys are fused at the lower pole, but a whole host of kidney problems. We see vascular problems, especially that vascular, I mean blood vessel problems, and particularly in the arteries. And this is an example of an angiogram showing blood vessels in the brain with out pockets and narrowings. And then we have the characteristic facial features, which is classically described as an inverted triangle. And in my opinion, people with Alagille syndrome are very cute looking. And so I have never good looking, and I've always felt very, I had a family recently asking me if their child was going to be cute when she grew up. And I was happy to say absolutely. And I think that it's really important to normalize this as facial features. We call it facial features, and that makes it medicalized and seem peculiar or odd, but it's not odd. It's just a description that healthcare providers use. There's nothing, I hope that there's nothing negative perceived about that at all. So if you have organ involvement in at least 3 out of 7 of these organ systems, you can be considered to have Alagille syndrome. And then, as I mentioned, most of our patients have a mutation in JAG1 or JAG1. A handful of patients have a mutation in the second gene called Notch2. As I said, Nancy Spinner is really good, is our all-time expert on genetics of Alagille syndrome, and she will talk much more about this afternoon. But I just want to emphasize that there are hundreds and hundreds of different JAG1 mutations or variants reported in Alagille syndrome. So you may not have the same as somebody else. Everybody can still have Alagille syndrome if that variant is described as what we call pathogenic, disease-causing. But the thing that's written in bold here, which is important, is that there are no clear genotype, phenotype correlations. And that means we can't predict what your Alagille syndrome will look like based on your gene change. And that's frustrating because even though we can use genetic changes to make a diagnosis, we can't, as healthcare providers, then predict what your liver disease will do, what your heart disease will look like. So even though we can even make some of these diagnoses genetically now, even before birth, we can't predict what the severity of liver disease or the severity of cardiac disease might be. So I think it's important to understand the genetics are helpful for confirming or making a diagnosis, but genetics don't predict disease course. This is just a note to say that we, in Nancy's lab many years ago, identified the second disease gene in Alagille syndrome, which is Notch2. She will talk more about that this afternoon for sure, but just to acknowledge that a handful of patients, and it really is a handful, have Alagille syndrome related to Notch2 changes. And it's important to say that if a patient has JAG1 related Alagille syndrome versus Notch2 related Alagille syndrome, they seem to look a little bit different. You're less likely to have facial features with Notch2 related Alagille disease. You're less likely to have cardiac issues, and you're less likely to have bone and eye issues as well. So it's what we call phenotypic divergence, meaning that the 2 patterns of disease are slightly different, even though we still do classify patients with Notch2 variants as having Alagille syndrome. But for the majority of what we're talking about over the next day, we're talking about what Alagille syndrome looks like related to a JAG1 variant. So that's a little bit of an overview of what all the different organ systems are that are involved in Alagille syndrome. And when you see that many different organ systems, and I led by saying that it's highly variable, Alagille syndrome can present, meaning come to clinical attention for the first time, very differently. The classical way that we see Alagille syndrome, especially in a liver clinic, is a baby with cholestasis. And by cholestasis, we mean a high bilirubin, high serum bile acids, deficiency of certain fat-soluble vitamins, and a heart murmur. That is a kind of a classic way that we may meet a baby as a first time with Alagille syndrome. But having said that, all of these other combinations can also be presentations of Alagille syndrome. An infant with tetralogy of Fallot, which is a significant heart defect with butterfly vertebra. A child with moya moya, which is narrowing of the blood vessels in the brain and strokes with facial features. An adult who's been itching their whole life and had an aortic coarctation repaired as a child. Or a child that has peripheral pulmonary stenosis, that's narrowing in the blood vessels that go to the lungs, and a horseshoe kidney. So these are very, very different presentations. And that's how I go back to each patient's Alagille syndrome presentation and journey is very different. And that's the onus on us as healthcare providers to personalize care and make sure that we get it right for all patients. The predominant features, though, are the liver disease. And so most of what we take care of in the clinics, in hospitals, is related to liver disease. And that's why a lot of my talk today will focus on that. But we very much recognize that each patient is an individual. Again, back to this issue of variability in the patterns of organs involved and the severity of organ involvement. So for most of you, or for many people, I would say, the journey started with liver disease, with a baby who's jaundiced. And many of you, this is just a diagnostic approach to what we do for a baby who has born with jaundice. And I just wanted to go over this because many of you would have experienced this. And we know that there's a whole host of different reasons why babies are jaundiced. But usually when we meet a jaundiced baby for the first time, the first issue is we do a lot of blood tests. We do an abdominal ultrasound. We will often do a liver biopsy. And the main thing that we're really doing with babies who present with jaundice is trying to identify this related condition, biliary atresia. But what's really changed for us now in the red box is the ability to do genetic testing earlier and get to our diagnosis of Alagille syndrome or another genetic cause much quicker in this diagnostic approach sequence. And I think this has really changed care in the last 5 to 7 years. I think if you were diagnosed with Alagille syndrome more than 10 years ago, you probably went through this entire sequence of blood tests, abdominal ultrasound, liver biopsy, cholangiogram, maybe a HIDA scan, sequential genetic testing. And now what we're able to do is very early on get straight to a genetic panel test for multiple genes, 90 genes in one go, and in many cases, not even do a liver biopsy. So I think the point is here that diagnostic approaches are changing. And 10 plus years ago, there was probably a lot more testing and more invasive testing. And now the shift has really moved to be able to do genetic testing earlier. And that's a good thing. So the point is here is you don't have to have a liver biopsy to make a diagnosis of Alagille syndrome. And that is something that has changed dramatically, even in my own career. So making the diagnosis of Alagille syndrome, you can do it clinically based on clinical features. A family history, if present, can be helpful, knowing that 40% of children who have Alagille syndrome have one affected parent. And then a genetic ways, which I said, a genetic diagnosis through a genetic panel. So that's how we kind of tried to get to the diagnosis. And now there's an opportunity really to think about this multi-system involvement in Alagille syndrome and think a little bit about some of those organ systems that we talked about. The facial features that I mentioned are very characteristic: broad forehead, pointy chin, inverted triangle. Why is this helpful? This is helpful for us as clinicians to help make a diagnosis. And some of you may have experienced that we can make a diagnosis from a parent based on facial features. And you can see the facial features are a little bit more, show a little bit more of a prominent chin. And that multiple times we will, when we're meeting a child for the first time, we'll look at the parents and we'll be able to say, oh yes, this parent is also affected. And that can be difficult as a parent to hear that news for the first time, because it could be that you were undiagnosed for your lifetime until you had a child that had severe liver or heart disease. And this is, I think, it's something that's important to help support our families through as an adult to get that diagnosis, perhaps if you didn't know before. And this is really where the facial features, it's not meant to be stigmatizing. I think the facial features are helpful to us as clinicians. That's the only purpose in talking about them. And that's why I show them to young trainees to say, you guys should recognize this. You need to not miss this. So that's the only reason why we talk about facial features. It's a diagnostic tool, nothing more. Heart involvement is incredibly important in Alagille syndrome. I said that the majority of my talk today will be about the liver, and I'm really glad that there's a whole session about the heart, because almost all patients with Alagille syndrome have cardiac involvement. Back to the issue of variability, this can be a mild murmur, just an extra a sound when you listen to the heart, all the way to a severe intracardiac lesion. By what I mean is holes in the heart or a big hole in the heart, one of the most severe being tetralogy or Fallot. And I think that it's important to understand that these are common in Alagille syndrome, and they can have severe impact on a patient's course and survival as well. We, as hepatologists, are constantly talking to cardiologists when patients have a severe lesion within the heart, trying to plan the best time potentially for transplant. And I'm sure you'll hear about that in the transplant session, that if you're planning transplant, how good or affected a child's heart is has a severe impact on that. So cardiac involvement, and if you have a cardiac involvement, being at a good cardiac center or being seen by a very cardiologist who understands Alagille syndrome is really important. And why is that important? Because we know that patients with Alagille syndrome and pulmonary artery disease, these are narrowings in the blood vessels that go from the heart to the lungs, that these patients have more difficult it's more difficult for them to recover from their interventions, and it's more difficult to do their surgery than a child who might have a similar narrowing the pulmonary artery that doesn't have Alagille syndrome. There's something interesting that there's something more affected about the blood vessels in Alagille syndrome in general, but particularly these blood vessels in these blood vessels that go to the heart, that make sure that the patients have a harder time. So I just think highly specialized care is really important if your child has a severe cardiac lesion. Renal anomalies, and I see a question just coming up on the chat about renal anomalies and Alagille syndrome, so hopefully we're addressing that here. So we had looked at this many years ago now about, first of all, the different types of anomalies or abnormalities we see in the kidneys in Alagille syndrome. And when we looked at almost 500 patients with Alagille syndrome, we found that almost 40% had some type of change in their kidneys. Now, some of those are just what we call renal dysplasia, just a brightness of the kidneys on ultrasound. So a fairly, I would say, a mild to moderate involvement of the kidney. Some of them are more important, like a structural anomaly, and some even have renal failure as well. And because of the high frequency with which we saw these types of renal anomalies, we added renal involvement as an additional defining criterion for Alagille syndrome. Now, for the most part, the renal anomalies in Alagille syndrome don't have a significant impact on life and course, for the most part. However, there are notable exceptions to this. One thing we have found is that after liver transplant, when all patients after liver transplant are exposed to immune suppression, we know that there's a risk of the kidneys being negatively impacted by those immune suppressant medications. What we have found is that patients with Alagille syndrome are more likely to have kidney problems after liver transplant when they are on immune suppression. So what are we saying here? What I'm saying here is that even if you just have generalized renal dysplasia, a relatively mild finding, the kidneys in Alagille syndrome are more sensitive, are more vulnerable. So for the most part, we will see patients with Alagille syndrome and kidney involvement do very well. But if they are exposed to immune suppressant medications, if they get another second hit, as it were, to the kidneys, they are more likely to have kidney problems down the line. I will also comment that as we're looking at our adult data, the registry data that will be covered by my team later, by Morgan later on today, we are also seeing that after liver transplant, that some of our Alagille syndrome patients are more likely to need a kidney transplant because of this exposure to immune suppression. So I think the general answer here is we're learning more about, we know about the structural problems, the way the kidneys are formed, and that's related to the JAG1 mutation. But what we're seeing is that over lifetime, if the kidneys are affected and then they get exposed to a second hit like immune suppressant medications, they are more likely to have problems. Skeletal anomalies, I mentioned, for the large part, don't cause a lot of functional problems for patients, but again, are useful diagnostically, such as these butterfly vertebrae. We pick them up on x-rays. This is actually a CT, but we pick them up frequently, and they help point to the diagnosis of Alagille syndrome. But there are cases where patients really are having bone, the way that bones formed are causing bone pain. And I think this is something that the Alliance has been really supportive about and looking at, and they've got a great work group, and you're going to hear more about that later. So I think there's more. I think we know a little bit about bone morphology. I think what we really need to understand better is why the bones in Alagille syndrome get more fractures, because they do get more fractures, and also why there's bone pain. So I think that we have more to understand in this area. I want to talk now a little bit about something that I think has been relatively understudied in Alagille syndrome, and we need to think about this more. I've pointed right to the beginning about blood vessel abnormalities in Alagille syndrome. So this is narrowings or outpouchings or some type of problem in the blood vessels in the brain and elsewhere in the body. We knew early on, when thinking about Alagille syndrome patients, that quite a few patients were having strokes as children, also as an adult. It was also it's not always been easy to try and predict who will have strokes, when they can have strokes. And you can understand that, we all understand that this can be very scary for our patients. In addition, we found that it's not just blood vessels in the brain that are affected, but blood vessels throughout the body. This was a study that we did here at CHOP, where we found that almost 10% of patients have either some type of blood vessel narrowing or outpouching, or have a bleeding event. And also we found that some of these could actually lead to very adverse outcomes and actually death. I think it's important to say that most of the blood vessel narrowings or variations that we pick up on MR imaging or on CTs do not cause problems. But I think what we don't know yet is why some patients have bleeding, when they're going to have bleeding, and how we can intervene before there's bleeding. So I think this is still a relatively understudied area. We need to get more neurologists and neurosurgeons to get interested in this problem with us. And that's an ongoing thing that we're doing here with the GALA data that you'll hear a little bit about later. So those are the main organ systems, apart from the liver, that I'm going to get to. I want to talk about two sort of relatively new things that we're thinking about with Alagille syndrome. One is about whether or not the immune system is involved in Alagille syndrome. There have been some emerging data from mouse studies and some clinical data that suggest that the immune system can be affected. In a clinical study from King's College in London, they found that 25% of their group of patients with Alagille syndrome had more frequent infections. I think the jury is still out on this a little bit. In all of our centers, we do take care of patients that have major immune defects. Those patients tend to get big problems, like they'll get meningitis at a young age, or they'll get serious bacterial infections. I want to emphasize that we don't see serious bacterial infections with Alagille syndrome. However, there is a signal that there may be some types of maybe viral infections or ear infections that do happen more often. So I think we still, again, something that we want to keep our minds open to. I wouldn't call Alagille syndrome an immune deficiency syndrome. I would not call it that in general, in the same way that our immunology call it, but I do think that there's more for us to understand. So I put immune dysregulation in my mind always with a question mark. What do we have more to understand here? The other thing that I would also talk about is thyroid involvement. So that thyroid produces the thyroid hormone. And again, from mouse data, we can see that there is a suggestion that NOTCH signaling is important in thyroid function. And when we looked quickly at this at our database in Alagille syndrome, we found that 5 out of 72 patients with Alagille syndrome have hypothyroidism. I think the issue is that probably as healthcare providers, we're not routinely screening for this. And perhaps if we screened more, we might find more. So I think that this is something, if a patient has fatigue, if a patient isn't growing, we should think about thyroid disease as well in patients with Alagille syndrome. Again, so immune dysregulation, thyroid involvement, not major disease features of Alagille syndrome, but something new that we are thinking about, because I think one of the things that, as the more time I spend thinking about Alagille syndrome, the more I realize that we don't know and we want to learn. So I like to keep an open mind about this. So now let's get to the meat of the matter, which is thinking about liver disease and Alagille syndrome. Again, this is for us the predominant disease feature that we're managing, that we're taking care of. And back to the same theme, it's variable. It can vary all the way from just having minor blood biochemical changes, meaning your labs are slightly abnormal, all the way to end-stage liver disease and needing a transplant. As I've said, on liver biopsy, if you do a liver biopsy, if you have a liver biopsy, you will find bile duct paucity. So again, this is this term where you have inadequate number of bile ducts, and it's because the JAG1 not signaling defect results in impaired bile duct development. So you're just not growing as many bile ducts as you need. That leads to this condition called cholestasis, this type of liver disease, which is manifest by severe pruritus, xanthomas, and also elevated lipids in the blood. I think I can't speak about how debilitating and awful pruritus can be better than those of you on this call who have lived with it. It's a devastating symptom. It occurs, you can see from that bar graph that it occurs throughout childhood, and as I know, into adulthood as well, and has multiple negative impacts on life for people dealing with Alagille syndrome. So I think one of the earliest things in the journey of trying to get IBAT inhibitors approved was when I was able to go to the FDA and try to explain to them how devastating this is as a symptom, and it was great that they listened and were open to understanding the severity of this. It's not just a mild scratch. It is a truly devastating symptom, not only for the patient, but really for the whole family. Xanthomas, these are these fatty deposits that we see under the skin. These are sort of classic pictures of that. People who have experienced these know that we don't surgically remove them. They are there. They can be, of course, disfiguring. They can also affect fine motor development. They can impact on when a child learns to walk as well, because they can be sensitive and even painful. So this is another disease feature that we see in the liver disease associated with Alagille syndrome. And so how do we take care of the liver disease in patients with Alagille syndrome? So two major things that we're dealing with in the clinic. One is to manage the itching, the pruritus. And this list of drugs is a list of drugs that we used to use. And then we used to focus on, and the other thing that we really focus on in clinic is nutritional support. Nutrition is incredibly important. I will not accept if somebody says to me that a patient with Alagille syndrome is small because they have a syndrome. I really think that that we have to maximize a patient's nutrition regardless of whether they have Alagille syndrome or not. And we can usually, and as a short person myself, you can't see me, I'm only 5'2", but I can tell you that 2 inches difference in height when you're a short person is incredibly important. So I'm very aggressive about nutrition in my patients with Alagille syndrome and want to optimize it at all times. So what are the sort of things that we can do for nutritional interventions? We can try to use different types of lipids or fats in a formula. We try to use something called medium chain triglycerides, so a high MCT formula, because these have fats that are more easily absorbed in the setting of liver disease. We can also increase the caloric density of a formula. And we can, and quite often we have to also include having extra calories delivered via a tube or a gastrostomy through the stomach, and sometimes even intravenous nutrition as well. And I think that I would say is that when you have liver disease and heart disease and maybe kidney disease as well, the caloric needs of your body are much greater than we can deliver just by mouth. So it is not your failure as a parent, it is not your failure as a child if you need a tube feed or you need gastrostomy feeds. You haven't failed. It's because your needs are astronomical. I always say sometimes we just have to deliver rocket fuel to get you to grow. And the most important thing is not to feel negativity or guilt about this. We know that growth is so important. We know that nutrition is so important that we want to accept that if we need to do it, if we need to do tube feeds, that we should do it and not and just understand that it's the needs of the body and it's not a failure to deliver those calories. Recently, from our Gala study group, we were able to generate for the first time growth charts for patients with Alagille syndrome. This is really an exciting development. And we have a calculator online where you can plug in numbers such as your age, your month, your length and weight, and then it will tell you where you fall on the growth curve. We're still trying to get these into clinical practice, but the paper is out. It came out last year. I'm very excited about it so that you can then at least see the journey of yourself or your child for as compared to other patients with Alagille syndrome. The other thing that's really important, as I said on that first slide for management, in addition to calories, is addressing fat-soluble vitamins. So fat-soluble vitamins are A, D, E, and K. These are the vitamins that are transported with fats and tend to be very deficient in patients with cholestatic liver disease, especially Alagille syndrome. So and I can't emphasize enough how important it is to get nutrition right and to get the vitamins right. The best approach to treating this is to have a multivitamin preparation that's been designed for cholestatic liver disease. The other approach is to use individual vitamins, A, D, E, and K, to give them out separately, or you can use a standard multivitamin preparation with some tweaking. My preferred option is one or two, and really is one. The vitamin that I am going to shamelessly promote here, I have no shares or anything in this company, is a product called DECA's Essential. This was designed by a hepatologist for supplementing fat-soluble vitamins in patients with liver disease, particularly the liver disease in Alagille syndrome. And it has the right ratios and the right amounts of the vitamins that are needed. I really would encourage, if your child is needing a lot of vitamins, it would be really lovely it's really good if you can advocate to say to your healthcare provider, if you're not on these, would I be eligible to get DECA's Essential, because it really is helpful and it's efficacious and it's cost effective because it's in one medication. You can give all the vitamins that are needed. You might sometimes need to give some extra vitamin D, but it's much more cost effective to do it this way. So I would promote this, but I just want to make sure in general as caregivers that you're aware that nutrition and vitamins are super important. So the next thing really, as I showed you, the other thing, the big mainstay of our treatment is management of pruritus. Now, pruritus, there was a question in the chat about, can it be only extremely itchy or mild? It's the whole spectrum. It can be mild. It can be extremely itchy you can be extremely itchy that you disrupt sleep, but all the gradations, and it can also vary in the time of the day. It can vary with the season. So it's a predominant issue. And sometimes I think that some of our patients actually get used to it. And then when you treat it, it can be incredible to know what it's like to live without itch for the first time. And I haven't experienced this, but I've heard it before. And I've heard parents say to me, wow, Dr. Kamath, the itch is treated. We got a new child. And that's like the most incredible thing to hear. And what has really massively revolutionized care and given us a whole new toolkit, a whole tool in our toolkit in the last few years are IBAT inhibitors. And I think it's such an incredible story about how IBAT inhibitors came to market that I think it is really worth going into it. And it has allowed us to stop using some of these other meds that just were not as effective. And it's really changed our care. And I'm really excited about that. And we're using them more and more. We're very fortunate in North America that we have access to them, in many parts of Europe, and it's extending across the world. And this is really a wonderful collaboration that those of us who've worked in this community as healthcare providers with the Alagille Alliance, and both companies, Mirum and Ipsen, is a phenomenal collaboration to get these drugs to market. So in order to understand how IBAT inhibitors work, we need to understand a little bit about bile acids. And I think because you're going to go to clinic and you're going to hear your healthcare providers talk about bilirubin, which I think is, that's in your standard blood panel. It's there. But you're going to hear a lot of people talk about bile acids as well. And what are bile acids? What are this mysterious products? So bile acids are made in the liver from cholesterol. And they circulate and they hang out in bile in your gallbladder. And then they go into your intestine. And then the body reabsorbs them. So 8 to 10 times a day in all of us, bile acids are being made in the liver, they're going into the intestine, and then the body is reabsorbing them. So this enterohepatic circulation is happening about 10 times a day in all of us. That is normal. Okay, that is happening normally in all of us as we ate something, it's happening more there. And these bile acids are really important because they get into the intestine and they help us digest fats and absorb fat-soluble vitamins. They're really crucial molecules. Now, this is just another representation of the same thing. What do IBAT inhibitors do? So what they do is, if you look at my arrow here, which is pointing down here at the intestine, they stop the body reabsorbing them. Why do we want that to happen with these drugs? Because we know that patients with Alagille syndrome have very high serum bile acid levels, and those high serum bile acid levels are associated with the itching. It's not a perfect correlation between serum bile acid levels and itching, but there is an association with them. And so what IBAT inhibitors are doing is that they're blocking the body from reabsorbing those bile acids to bring down the bile acid levels in the blood and the bile acids within the liver. That's what we're trying to do. So this is all about getting the body not to reabsorb bile acids and let them go out in the stool. So they just get wasted in the body. They get wasted and come out of the body. And that's the goal of IBAT inhibitors. So as I mentioned, both companies supporting this meeting today were tremendously important in helping us get these drugs to market. I'm just going to describe these studies, and there may be participants in this on this call who are in these trials or who have helped run these trials. And it's such an incredible story for us, because so much of what we do in pediatrics is borrow drugs from adults. Honestly, that's often what happens. People haven't done studies in children, but we see, oh, this drug works in adults. They'll do some kind of maybe a minor study to say, could this also work in adults? Sure. And then we use drugs in adults. This is a very different story, because these drugs, the original studies that got these drugs to market, were done in kids with Alagille syndrome and also PFIC. It's so wonderful to see that our community, this community of people on this call, participated and led these studies that have got these studies to market for everyone to benefit from. But the work started here in the Alagille syndrome community. And I just think that's something that we can all really, really be proud of. So the adults are now looking to us and saying, oh, hey, this class of drugs looks really, adult doctors are saying, this class of drugs is really interesting. Can you teach us about them? And we as the pediatricians and we as the Alagille syndrome community have the expertise. So this was one of the studies led by Miram, where 31 patients with Alagille syndrome were treated with maralixibat, and then for several weeks, and then half of them were put onto placebo, meaning that they were given non-drug, and then they were returned to being on maralixibat. And what did we look at when we were following in these patients? What you'd see is you follow the red line in this chart. What this chart is, the bottom part of the curve is time, and the top part of the y-axis of the curve is serum bile acids. So what happened to patients' serum bile acids when they were put on these drugs? So you can see in the red line, everybody's serum bile acids went down when they were put on these drugs, this on maralixibat. So that's great. That's what we wanted. We wanted to lower the serum bile acid levels so that we could treat itching. So that's exactly what happened. In the gray box, you will see that gray shaded area, that's when half the group was taken off maralixibat and given a placebo. Well, look at that. All of their serum bile acids went up. And then at the end of the 4-week period, they were restarted on the drug and their serum bile acids went down. And then the serum bile acids stayed low for a long, long time in the clinical trial. Fantastic. That speaks to the mechanism of the drug. And then if you look at what's most important to us and most important to you is what happened to itch scores. So here, the same x-axis is the time, and then the y-axis is a score, the HRO score, which was a caregiver observed score. So a parent or a caregiver was asked, how itchy was your child? Again, same thing. When they were started on maralixibat, all of them, their itch scores got better. When they were taken off drug, those patients who were taken off drug, their itch scores went up. That's the gray bar. And then when they were returned to drug, their itch scores came down. And then those itch scores stayed down. Really exciting. Ipsen ran another study called the ASSERT study. And in this study, a different study design, but this is just adding to the body of work that shows that IBAT inhibitors work. They had 52 patients with Alagille syndrome, and they gave 35 of those patients odevixibat, and 17 were given placebo over a 24-week period. And then they did the same thing. They looked at serum bile acid levels. That's the first graph there. And then they looked at pruritus scores. And here again, you can see the red bar is the patients who were treated. The red line is patients who were treated with odevixibat. Their bile acid levels dropped, and they dropped early, and those changes were sustained. And then here in the bar graph, you can see that patients who were treated with odevixibat had statistically significant improvements in itch scores. So based on these two important trials, done in patients with Alagille syndrome, you can see that IBAT inhibitors are very effective at reducing serum bile acids and in improving itch. And there were lots of additional studies that also showed that we improved quality of life, probably growth, and emerging data that we could actually be reducing the need for liver transplantation over time. So this is very, very exciting stuff. What about the safety of these drugs? Well, very happy to see that there's been in the trials, we were worried initially that maybe our patients would see a lot of abdominal pain or diarrhea because there's more bile acids within the colon. But actually, we do see that some patients can initially have some adaptation, can have some abdominal pain, have some diarrhea when they start these drugs. But actually, overall in the trials, there was very little difference between drug and placebo. Fat-soluble vitamins potentially could have gotten worse, but I think if we pay attention to them, it's not a major problem. And some patients see an uptick in their liver blood work when they start on these drugs, but it largely settles down. So these drugs are pretty safe and well tolerated. And actually, they don't even get absorbed into the bloodstream. They stay within the GI tract. So this has revolutionized how we treat pruritus, itch now, and it's been a game changer for us and for patients. So I've talked a little bit about what the liver disease can look like. We've talked about how bad the itching can be. We've talked about a new drug in our toolkit. But what happens overall to our patients with Alagille syndrome and their liver disease? We can treat the itch better, but how are they doing? So this is a study from the Children Network. The Children Network is an NIH-funded network across 14 centers across North America, where we looked at what happened to patients with liver disease from these 14 centers. And what we found when we did this study a few years ago now was actually quite surprising. What this shows is that in patients with Alagille syndrome who were seen at one of these 14 centers in North America, 70% of them had undergone a liver transplant by the age of 17. Now, I'm going to say when I saw this information for the first time, I was surprised because I didn't expect it to be this high. And it was definitely a surprise. And we see that most of the transplants happen in the first few years of life here. But there is an ongoing need for liver transplant in what we call the middle age of childhood, which is around the age of 10. And this was sobering information to us when we first saw it. But the other thing that occurred to us was that these 14 centers that we were collecting this information from are all liver transplant centers. So in a sense, the data that we were collecting from these centers was biased because what it was looking at was the most severely affected patients with Alagille syndrome liver disease in the country. So I hope that makes sense. What you have is what is a bias in the data set because you're pulling data from the centers that are where patients are being sent to for transplant. So only the sickest patients with Alagille syndrome are being sent there. And that led us to set up the part of this and multiple other reasons made us think that we should set up the GALA study. This was set up with strong support from the Alliance to look at Alagille syndrome across the world. And not just to look at Alagille syndrome at a subset of liver centers, but to get a more broad look at what Alagille syndrome looks like at different centers around the world, big centers, small centers, to get a real world view of what Alagille syndrome looks like. And Quinn, later on this morning, will talk to you more about GALA, but what I wanted to say is that we have now collected data on more than 1,700 patients with Alagille syndrome from almost 80 participating centers in almost 40 countries. So this is what we hope and think is a very representative view of Alagille syndrome in the world. And the first time we looked at the data set, we looked at almost 1,200 patients with Alagille syndrome. We saw that about 3/4 were reporting pruritus and about 1/4 had xanthomas. And then we wanted to look at what their liver disease looked like. So this is a curve where you're looking at how many patients in this group ended up needing a liver transplant. The red line is the liver transplant group, and the number in this group was 50%. So if you'll remember, when we looked at that subset of US centers, 74% had a transplant by the age of 18. But when we look at this group, which is a more representative group, it's about 50%. So this is useful information, I think. We now know that if you have liver disease in infancy with Alagille syndrome, you have a roughly 50% chance of needing a liver transplant by the age of 18. The average age at transplant is about 2.8 years. So most of the transplants do occur in early childhood. But by 18, there's still some kids in that middle age of childhood who will need a liver transplant. We were also able to look at labs, and we found that your AST, ALT, GGT, none of these labs help predict who will need a transplant. The one lab value that is helpful is your total bilirubin, and you can use the total bilirubin between the ages of 6 to 12 months to get an assessment of the prediction of whether or not you'll need a transplant. Now, I want to be really clear here. You don't make a decision to do a liver transplant based on one lab value. But what I will say is that this lab value is the most predictive tool that we have. So it's an important element in trying to decide who needs a liver transplant. It's one important piece of the puzzle. But just because your bilirubin goes above a threshold, above 5, it doesn't mean that you instantly need a transplant. It's more looking at the trend of bilirubin. I will also just say is that when we looked at of this whole group of patients and 50% ended up needing a transplant in 1,200 groups, what was the leading indication for transplant? So it was pruritus. It was severe pruritus. But remember, this information was collected at a time before we had IBAT inhibitors. And I'm fascinated to see now what is going to happen in the next era, in the IBAT inhibitor era, because we have pruritus is treated so much more effectively. We are likely to be doing less liver transplants. And that is such a wonderful thing. So I would love to be able to give this talk in 10 years and say the rate of liver transplant is no longer 50%, but it's down to 30%. And is largely because we have IBAT inhibitors. So I don't know. I don't know where the future's going, but I think it's pretty positive for liver disease outcomes in Alagille syndrome. And I just think it's a wonderful time to be in this community, to see that pruritus is no longer such a dominant feature. I'm not minimizing it for those patients who are not responsive to IBAT inhibitors. For those patients who have a response and then lose response, it is still a devastating symptom. But we have greatly reduced the burden of pruritus in our community with the advent of IBAT inhibitors. And for that, we have to thank Miriam, Ipsen, and the Alagille Alliance, and all of those of you who have participated in this trial. So it's a wonderful, I think we've got a really good present and future for Alagille syndrome. I'm just going to end now with one last slide, and that's here. If nothing else has been shown to you in this 101 talk, is how much the multidisciplinary and interprofessional team is essential. It's not important, it's not valuable, it is essential in taking care of patients and families with Alagille syndrome. Can't emphasize this enough. This is what is illustrated in your next 2-day symposium, because each of these different groups will be represented, and we need each of them, and you need them in a different combinations in order to achieve optimal care. And even individuals in the same family will need different combinations of this care team. So I'm really grateful to all of my colleagues who get to work with me as part of my care team. And the one thing I'm realizing is I'm somewhat missing on this slide is that I could add the Alliance as right on top of the whole thing as the key member of my team. Somebody just pointed, I'm missing ophthalmology. Yes, I'm sorry. I just realized that that's missing as well. Thank you for calling that out. I will add that next time. But it's just incredible. You could keep adding. You could add endocrine as well. You could add neurosurgery as well. Again, it just shows how much we're still learning and how much we still need to do. And you just have to pull in the right care team members depending on what your patient's needs are. So with that, I will end, and I have left a few minutes for questions.
Thank you so much, Dr. Kamath. Amazing, as usual. We so appreciate your time. We do have a few minutes for questions, 10 minutes to be exact. So if anybody has any questions, please feel free to just speak right up. And we'll watch the chat here too.
Yeah, I tried to look as I was going. I got some great call outs during the chat, which was wonderful.
You did great with that.
It was nice. It's nice. I feel like I'm having a conversation, so that's good.
Hi, Dr. Kamath. Can you hear me okay?
Yes, hi.
Okay, hi, my name's Catherine. I asked a question in the chat about kidney involvement, and you mentioned the horseshoe kidney and some other renal involvement. I think I've heard it around like the narrowing vessel as well. But my daughter had smaller kidneys in her last scan. Is that something that's seen in Alagille's kids? And like, yeah, if you could explain that to me in any way. I was told they were smaller, but I don't know a lot about it.
Yeah, no, absolutely. So the JAG1 gene is involved in NOT signaling. We know NOT signaling is very important for the development of bile ducts in the liver, but we also know that that NOT signaling pathway is incredibly important for kidney development as well. So it's all part and parcel of the same thing. That in fact, the liver and the kidneys are developing in utero at the same time. So in the same way that you can have an inadequate number of bile ducts form, the kidneys can also not form optimally. But I think the key issue with the kidneys, as we would for the liver as well, is one part is the structure, like so they're smaller. Fine. But the next part is what's their function like? So that's what I would try to tease out with your kidney doctors is they may look smaller, but are they functioning effectively? And the answer to the two of those can be a little bit different because you can have a smaller kidney that works perfectly, in which case that's great, or you could have a smaller kidney in which there's scarring or problems in the kidney that impact function. And then the next part of what I was alluding to in my talk is that if the kidneys get a second hit, so for instance, if the kidneys are exposed to immune suppression medications after liver transplant, first of all, those medications are essential. So there's no issue about using them. They have to be used after liver transplant. They're non-negotiable. But what we do try to do is to use lower doses of them in patients with Alagille syndrome, knowing that their kidneys are sensitive or vulnerable and are more likely to develop problems in exposure to those meds. So hopefully that answers your question. Separate out structure and function if you can, and then think about in the future if your child's kidneys are going to be exposed to something else or a drug that could affect their function in the future. That could be a dynamic issue.
Okay, thank you so much. And then my second question is around pruritus. Because you said it like varies in severity, like it could be very mild. Are folks in the medical community now just recommending like even if it's mild, like anyone should go and I got inhibitors, or is it just kind of waiting for it to be in that more extreme cases?
Oh, that's a great question. Are you recording this, Roberta? Yes, you are.
Okay.
I think, okay, I'm going to answer this truthfully. In the clinical trials, patients had to have moderate to severe itching to get in the clinical trials. And in a clinical trial, that's what you want to do. You want to treat the most severely affected patients to see the biggest benefit. That was very well demonstrated in the trials. In our clinical practice, I would say that we want patients to be itchy. And I think whether pruritus is mild or severe is to some extent how much it's impacting you, how much it's impacting the family. I would say that I find this class of drugs very safe to use. And so I'm a proponent of using them. So I will encourage the use of them. I think there are also emerging data, and I'm going to be very clear, this is not in the FDA or EMA approval. So this is not approved from a regulatory basis, but we have emerging data that IBAT inhibitors could potentially improve the liver itself, not just treat the symptom, but actually be beneficial to the liver. So I will say that as a provider, I have a low threshold for starting them. I'm in general relatively keen to start using them. I see one of my colleagues, Dr. Lee Bass, on the call, who's also a very experienced hepatologist. He's shaking his head. Oh, he's nodding. I think he's not shaking his head, he's nodding. So I think he also agrees. I think many of us in the community have found benefit in this class of drugs. So the FDA approval is based on pruritus. I think most of us are feeling like this is a good class of drugs and that we are eager to use them to help.
Amazing. Thank you so much. And thanks so much for all your work you do in this. Just appreciate it so much.
Oh, that's very kind of you.
Binita, there's a really good question in the chat by Patricia McDonald. I've read about a mid-childhood plateau in symptoms and presentation, but have struggled to find studies with details. Can you speak to any trends you see there?
Yeah, that's a great question. And I think the issue is that most of the complications we see associated with cholestasis, and by that I mean the itching, the poor growth, the xanthomas, we see those in the first few years of life. And that's why the median age at transplantation, or the average age at transplantation, is 2.8 years. Most of those complications of cholestasis are in the first few years of life. And then those complications do indeed seem to plateau. A couple of reasons. Either because in some patients the cholestasis gets better, which is great, but actually it's because a large number of those patients just get a transplant. So they fall out of the pool, if that makes sense. And so the patients that we see in the middle age, the mid-childhood, they have a plateau in the symptoms and presentation, either because they did genuinely get better, or actually because the majority probably just got transplanted. So the ones that are in childhood, mid-childhood, what they tend to see is more complications associated with scarring of the liver. So it's a different type of complications that we see. They may have problems with bleeding from varices, sort of swellings in the blood vessel around the esophagus. In fact, I'm seeing Dr. Bass's face again. He's a world expert on that, and may speak to that later on in one of his sessions. So you may see more problems with issues with bleeding from varices or with ascites, extra fluid in the belly, rather than those classical symptoms of pruritus and growth failure. So it's a plateauing of those cholestasis symptoms, but you can still have a risk of transplant later.
Okay, we have two more questions here. Shami Ravishankar says, some of us experience heightened itching during specific times, right before and during periods, for example. Do you see any rationale for prescribing the inhibitors for just during those times, or is it better for the patient to be on it more generally?
Okay, first of all, hi, Shambi. Nice to hear from you. I saw you pop on earlier. I think it's a great question. So the way that the trials were set up for IBAT inhibitors, they were not set up for on-off treatment. They're not what we would call a PRN medication, meaning it's not a medication, a class of medications that we believe works well if you use it on an as-needed basis. We believe that the way to use these medications properly is that you're lowering the serum bile acid levels, and that's leading to sustained benefit. So I think that as far as our knowledge is right now, if a patient is getting more itchy every month and that itching is really bad, it would probably be better to be on them all the time. That's, I think, what we know right now. I don't think we know about an on-off mechanism for these medications. I mean, I suppose theoretically it would, but I don't, having talked to some other experts in the field, I think we have also seen patients who've come off and then go back on and don't have as good a response. So I would not recommend, based on what we know today, to go on-off on a monthly basis.
Thank you so
Thank
much.
you for that.
Thank you. And one last question, is elevation of LFTs during a growth spurt seen in ALGS? If so, is it just a watch and wait situation?
Most likely, I would say. I don't think that that's okay. We haven't studied that carefully to say in a growth spurt how much enzyme elevation is there. But I think if there are transient changes, that's fine, and it would be a watch and wait. When we looked in the Gala study and we identified bilirubin as a predictor of outcome, one of the things we realized is there is so much variation in ALT, AST in patients with Alagille syndrome. And it's really hard for us to know what to do, because you may go back to clinic after a 2-month visit and your ALT has gone from 200 to 360. And that bump up looks alarming. And certainly you need to pay attention to it. And is it related to a growth spurt? Is it related to a virus? Is it related to something else? And then actually often we see it comes back down again. So I think my message here is, if you're being taken care of by somebody who knows what the liver disease of Alagille syndrome is like, they will hopefully be able to reassure within variations, address variations when they're clinically significant, but for the most part, changes in ALT and AST are not associated with outcome. If your ALT goes 100, 200, 75, 300, that does not mean you are more likely to have a liver transplant. It's your variation. We need to try and understand it, but I try not to get overexcited about changes in ALT and AST. The lab that makes me concerned is total bilirubin and conjugated or direct bilirubin. Those are the labs that we get more concerned about. Same with GGT. GGT also, surprisingly, I think, to me, did not turn out to be a predictor of outcome. And I'm sorry about it. I've now gone 1 minute over time. So I cede the floor back to you.
Thank you so much.